Hello friends, my name is Savinder Virk and this is MSN 597. This is Professor Nguyen's class and today we're going to talk about UTI. A 72-year-old male who came in with a UTI, but at first it was very hard to notice that this could actually be the problem. It actually felt like um, a outburst of agitation and aggressiveness and worsened dementia. But we'll talk about that in the further slides. So, Dr. Wen mentioned that if there was any standardized procedure, please mention it. So I put it in here with the first slide. Standardized procedures are guidelines or basically gold standards that are either set by your hospital or set by the CDC or the American Physicians Association, depending on what the problem is, how we are to approach it, and what information we need from the patient in order to treat this problem. So, a standardized procedure for a urinary tract infection follows the same guidelines. It's a step by step procedure. It starts with the doctor actually knowing the definition of what is going on, whether it's what happens when a patient has a UTI. What is the epidemiology? What is the history, what is the epidemiology of the disease? So basically, a UTI is a urinary tract infection, as we all know, that can start from within the bladder, from the ureters, and go up to the kidneys, or it's somewhere within the urinary tract infection. And most of the time, it's just opportunistic bacteria that's already present in our body, and during our weakened state of illness or stress, it starts to act, or poor hygiene, that the patient can actually develop one of these problems. So, epidemiology, how many people are actually affected by this? So the CDC claims that about 65 million are geriatric people, are hospitalized for UTIs. Mostly people think that these people have dementia or they have Alzheimer's. That's why they've started acting out, or they've started acting out because of old age. But sincerely, UTIs are a very big epidemic amongst the geriatric patients, and a lot of these patients end up in the ER, end up very, very sick because of them. And sometimes these things get misdiagnosed, and at the end of it, you see, oh, the patient just had a UTI. Why were they brought to a mental facility or dropped off to a mental health facility? As being a mental health nurse, I see this all the time. I wonder why the doctor did not take care of the UTI at the emergency room, and why the patient was transferred over, or why the patient was directly admitted for increased agitation and confusion instead of being treated for a UTI. So, a lot of money wasted there. The patient's health wasted as well. Basically, so we'll do a history, we'll do a physical, a diagnostic test. When I put the word management there, I am looking at a multidisciplinary approach from standards of social worker, case manager, family, doctor, physician, nurse practitioner, everybody coming together and making and helping this and the patient, helping this patient make a decision, or any patient make a decision. The treatment of the disease, how would we treat it? What education would we provide to the family and the patient, which is very necessary. Sometimes dementia people will not understand what's going on, what's around them, so it's in best interest of the patient to educate their family. A follow-up is always required and recommended to make sure patient is infection free. Always follow up on your patient who's had any type of infection, because as we all know, they will not finish the antibiotics. Or sometimes they will finish the antibiotics, but they won't get better. So that's when we need to bring them back and decide whether or not we need to do more tests, or we need to figure out if the antibiotic we gave is not working for the patient, which one will work. So next, I have opened up over here slide 3. Yes, it is slide 3. Mr. ST, 72-year-old male, height 6'1", weight 157. I think I have the BMI later. He's a Caucasian American male, came in with his wife. He's alert and oriented to himself, but couldn't tell me much. He was a poor historian. So the wife actually told me the most of the health history and Upon physical examination, we noticed a lot more things. So she reported that her patient has Alzheimer's dementia, and we have been treating this patient for a long time at our clinic. And I've seen him a couple of times earlier before, and I definitely saw that this was not his regular behavior. He is forgetful, but he's on the very first stages of Alzheimer's, not like progress to the point where he started forgetting a lot of things. But today he was definitely confused and definitely didn't understand where he was, what situation led him over there. She reported that he kept trying to get out of bed, turning on the lights, talking to people he didn't know, and kept pointing at things, having visual hallucinations. She said it usually got worse at night, so you would think that it's sundowners as one of the differential diagnoses because the patient does have dementia. So those were the different things that were running in my mind when she was talking to me, and because not completely to the point where I'm just focusing on the patient and listening to them. In the back of my mind, I'm thinking, what else is going on with this patient? So his wife has reported increased agitation, wandering at night, less sleep, definitely having visual hallucinations because while he was sitting there, he was still talking to his imaginary friend and actually getting very agitated with him as well. She also reported urinary incontinence, which the patient has never had before, but she said that lately, for the past 4 days, he's just been peeing everywhere he likes. Patient had no known allergies, different medications he was taking. We've been treating him for hypertension with a diuretic, hydrochlorothiazide, and amlodipine, atorvastatin for his hyperlipidemia, and Aricept was something that his psychiatrist started him on for dementia. Moving over to slide 4, past medical problems, like I said, hypertension, dementia, hyperlipidemia. He had an appendectomy at age 14, past family history. Both his parents had hypertension. Mother actually had an MI. Father and younger sister, as we can see, had diabetes. The younger sister also has heart failure, like the father did, and the younger sister has chronic kidney disease. The father had high cholesterol. So basically, we can see the trend that runs in the family where they say, you sometimes you have your parents' bad genes, and sometimes it's bad eating habits. Patient's wife reported that patient was updated with all immunizations, had a pneumonia shot at 65, flu shot 2 weeks ago. There's a very big factor here that most NPs or doctors forget to ask their patients. And I think it's best practice to ask because it's not only the job of a psychiatrist or a social worker or a psychologist to ask these questions, therapist to ask these questions. What is your social life like? Where do you go? Do you go to church? What do you do for fun? What are your hobbies? How do you manage your stress? Are you exercising? What type of diet do you follow? These questions sometimes we skip them. We don't Sometimes they make us difficult to ask the patient, so how's your sexual life? Are you happy with your partner? Do you feel safe at home? How's the safety at your house? And these questions are very necessary to ask because with that we skip portions of nonverbal cues. If a patient is in a dangerous situation, they'll give you a nonverbal cue, but they won't tell you out front. So, like his wife mentioned that she doesn't go because the patient's wandering and restless. They don't go to church. They don't go to family outgoings. The family comes and visits them during the holidays in the summer. She doesn't go to any social gatherings. And so there was a point where saw a lot of caregiver stress here. The caregiver is so focused on the health of her husband that she's cutting out of all the things that she liked. And the chance of her falling in depression at this point, or her having depression at this point and anxiety, is very high. So we're not only treating the patient, we also have to take care of their family member as well. She reported that she cooks for him at home. They eat a low fat diet. They drink Ensure between their meals. Moving on to slide 5 is just a review of this patient's symptoms, or systems actually. Basically, they denied most things, didn't have any problems. Last bowel movement was on 11:05, and patient was poor historian, so wife gave most of the information. Last eye exam checked out 3 months ago. Dental exam was last year. Ear exam was 6 months ago. Both patients, they said they have Medicare Part A, B, and D, so they were well off financially. They had both retired as teachers, so they said they had a good steady income, and their children actually helped them, so they didn't have problems financially. They were stable, they had their own house. So, as a practitioner, it's very important to ask the question about financial situation, because without that, and you don't need to ask the patient flat out, how much money do you make? It's better to ask, what's your occupation? Are you satisfied with your job? Do you think you make enough to provide for yourself and your family? These type of questions can indicate you what type of medication or what type of treatment or tests you need to order for your patient, so that you know that they're affordable and the patient can actually follow up with everything, instead of being ordering very expensive tests and the patient doesn't go to test and the condition just degresses from there. So, patient actually, I had to ask him, do you have thoughts of hurting yourself and others? And he kept repeating, why would I hurt myself? Why would I hurt my wife? You don't know what you're talking about. So, which was not his normal behavior. So, moving on to slide 6, which was my objective and physical exam. As you can see, his blood pressure was within range, heart rate was 90, a little bit elevated because of him moving around and being agitated. He's in a perfect BMI at 20.7, healthy. He's slightly frail, oriented to only self. Arcus is present, that ring around the eyes. Pupils were round, equal, reactive to light, and you can read this objective physical exam. There was nothing that was not that was out of normal, besides the patient's psychosocial behavior. He has mild arthritis with old age. You know, he didn't exercise a lot, besides except for walking around. He was definitely hydrated. Skin had normal turgor. So I'm going to go ahead and move around to the diagnosis part of this. So I decided that we gave the patient a urinary test, and the patient, actually, I'm going to come back to slide 7 and 8 later. We're going to jump over to slide 9. We did CBC just to make sure the patient didn't have any bleeds because of unreported falls or any infection or inflammation that was present. We did a CMP to check for electrolyte imbalance. What else is going on with the patient? Is the patient's kidneys functioning properly? Is the patient's liver functioning properly? Most times, most of the things that I have noticed, even on a med-surg floor, I used to work for GIGU, the patient's urea level would go off because kidney wasn't functioning properly, and the patient would have delirium, or they would go into a stage of psychosis. So it's very necessary to make sure that we are checking for those things, and we're ordering the right tests. So we did a urinalysis to check for urinary tract infection at the facility. We do have an X-ray machine, so one of our techs did a chest X-ray to rule out a respiratory infection. And we did the MMSE, the mini mental exam, to check for acute onset of delirium. So the patient did not have delirium. So the patient did have delirium, I'm sorry, but it was caused by the urinary tract infection. So a urinary tract infection occurs when a patient has an organism present in their bladder, urethra, or ureters. It can happen by improper way of cleaning, and since we knew this patient did have Alzheimer's dementia, but it wasn't that worse to the point that where he got confused and everything, but if there is something there was a portion that was missing that I couldn't actually place my finger on. But considering, and after talking to my preceptor, we decided that this is acute onset of delirium, especially since the mini mental test had a high score on it. And these patients are seldom able to identify. Some patients can tell you if they're having dysuria, frequency, burning, or they're having too much incontinence. But since this patient did have did have dementia, and they were also had acute onset of delirium, he could not tell us anything. So in this situation, you take your evidence of what you have and you put it together to build a treatment plan. So this was my primary diagnosis. I had three different differential diagnoses. Electrolyte imbalance. He's on hydrochlorothiazide, which can cause hypokalemia, and hypocalcemia, both of which can cause the patient to go into metabolic acidosis. As we know, metabolic acidosis can cause psychosis and sudden delirious state, but it didn't explain the incontinence. But it can also be ruled out with blood work. So we knew the psychosis, patient has dementia, and this can sometimes lead to agitation, aggressiveness, but it was all of a sudden everything started happening. This is the difference between delirium and dementia, which is one of the questions that is always asked on board exams. What is the difference between delirium and dementia? Or they'll give a case scenario and they'll tell you, is the patient delirious or is the patient just having common effects of dementia? Delirium is always acute onset. It just happens out of place, nowhere from go, and it goes boom. Dementia, on the other side, is a slowly progressing disease process. Usually, you will see delirium with patients who are withdrawing from alcohol or drugs. They'll be fine, and then within a couple hours, they won't be fine. Like they'll start acting out, or they'll start having auditory visual hallucinations. The patient does have a history of COPD, which I forgot to mention earlier on, and during his tests we saw he had decreased oxygen his tests were fine, but sometimes decreased oxygen supply to brain and tissue can lead to tissue damage and cause delirium. If the patient has pneumonia, then the patient can act restless and agitated due to hypoxia. But during his auscultation of his lungs, I didn't hear anything, and then the chest x-ray didn't show any signs of him having pneumonia as well. All right, now going back to slide 8. I'm sorry. I did do that already. Never mind. Back to slide 9. So the results for your analysis were positive for nitrites and leukocytes, which will tell us if the patient has nitrites. Sometimes the patient might have leukocytes present, but if the nitrites are positive, it's usually a UTI. Chest x-ray was negative for infection. Score of the MMSE was 12 out of 30. Last score was 18 out of 30 last month. So patient positive for acute delirium. Treatment, which according to the standardized procedure for this facility is cephalexin 250 milligrams every 12 hours for 5 days. And you can also, that's for the UTI. Haldol is a BID for agitation, increased restlessness, and to continue regular home medicine. But at this point, when we were handing the prescription to the patient, to the patient's wife, she requested that her husband be admitted. She said that he wanders all night, she can't take care of him, she hasn't slept in 3 days, she's really confused, and she was crying at this point, she was really asking for help. So upon the insistence of the family, we had to send the patient to the hospital so that he can be taken care of and medication can be given IV, since he was refusing most of his medicine, as she reported. Moving on to slide 10, follow-up in education. Always complete all doses of antibiotics, never stop until all gone. Make sure to drink enough water, use yogurt as regular probiotic, and to maintain normal flora, bacterial flora of the guts. Always keep appointments with doctors and specialists, as I talked about earlier, 7 days before running out of medication. Take medication as directed. If symptoms persist, take patient to ER, or if agitation continues, call 911. If when the patient feels like they can't stand or walk, I'll call 911. This is a major thing that most people skip over. If you ever feel like you can't stand or you can't walk or you can't lift your fingers or your hands or your body parts, it's necessary to call 911 or have a family member call 911 for you. Also educated the patient about allergic reactions like rash, hives, difficulty breathing. I also educated her that Haldol can cause extrapyramidal symptoms. As we know, shaking, eye drooping, uncontrollable eye movement, uncontrollable movements of hands, feet, arms, legs, heads, eyes, or mouth. Plus, I told her Haldol can also put the patient in a rigid stance where they can't, instead of uncontrollable movement, there's the patient just has rigidity and can't move at all. Tardive dyskinesia is something that is heard of, but as a mental health nurse, I've also seen situations where patient got Haldol and all of a sudden patient is like rigid as a stone. I think it's called neuroleptic malignancy. I think that's what it is. I will look that up further and clarify with you guys if that's the situation. I actually did have a patient that ended up having that after getting Zyprexa, and we had to immediately medicate him because he started having hyperthermia. It was a very dangerous situation, but gladly we were at the hospital during that time. Right, and with this, I'm going to go ahead and conclude this slideshow. These are the different places where I took references from. As you can see, I used the U.S. Preventative Services Task Force on Cognitive Impairment in Older Adults, the CDC, definitely for all the different numbers and all the values that I needed to collect. And all these are like some case studies and evidence-based research that was done on treatment for geriatric patients. And there is one in here. Yes, Bolts, 2016, evidence-based geriatric nursing protocols for best practice. This is available in our library. If anybody would like to look at it, it's in eBook Central on ProQuest, and they provide step-by-step information on how to take care of a geriatric patient who has a UTI. So it's a lot of good information. Thank you for listening. Have a wonderful day.